Hello, we're back, and we have the very last video lecture. In this video lecture, we're going to cover health record content across different types of healthcare settings. And again, the health record content requirements will vary based on the setting. If you think about this, this makes total sense. Behavioral health or substance abuse facilities will have different needs than acute care hospitals. A lot of these will depend on the setting. OB and newborn health records have entirely different requirements, right? Even though it may be referring to quote unquote mothers and babies. For the OB, we need to have the prenatal information and the labor and delivery record. Newborns' APGAR scores need to be kept. These are the standardized scores that are assigned whenever a baby is born, right? One of the things I can recall for our neonatal intensive care database that we had at Kaiser Northern California region is when we transitioned to Epic, a lot of the neonatologists were documenting the APGAR in the narrative text of the note instead of in the field that it was designed to be put in. Then when we went to run reports, we didn't have anything on APGARs and it caused a lot of commotion. Emergency department records have also different requirements, right? Think about if you've ever been seen in the emergency room or reviewed emergency room records. They always write how the patient arrived at the emergency room, whether they're going to be triage per the emergency transfer um, liability act, the EMTALA, right? So if somebody's not, that covers people not, hospitals not doing what they call patient dumping because they don't want to take care of somebody without insurance, right? Those types of requirements need to be documented. And then finally, when people leave against medical advice, they typically have to fill out a form, they get tired of waiting and all that. They can do that, but we don't want the patient's family coming back and having an issue. So we have all different types of documentation requirements for patients leaving against medical advice. Ambulatory health records are the ones that many of us are familiar with. We get the after visit summary from Oregon Health Group or Kaiser or what have you. And a lot of these will list the demographics. They'll list the current problem list. At least we hope it's current, right? The ambulatory surgery record is almost like an abbreviated inpatient hospital surgical record. It'll have the reason for surgery, the history, the exam, the procedure itself, all those things that you see within the hospital surgery record. And of course, we have tests, right? These are diagnostic imaging, labs, cytology, all these things that the ancillary departments contribute that make up the health record. Physician office records run the gamut. A lot of them will cover preventative care, minor injury, illnesses, what have you. And then long-term care. Long-term care are or what they call residents. And one of the key things is this one right here. The resident assessment instrument, right? For patients that are staying in the facility for the long haul. The other one is the minimum data set or the MDS. Currently, we're using MDS 3.0. Rehab facilities have the minimum data set, the MDS 3.0, right? The resident assessment instrument, the interim payment assessment, and then if patients are discharged or transferred, they have a discharge assessment. Behavioral health is in a lot of ways very similar to outpatient or inpatient content, but a lot of times we get into the family and the caregivers, right? Child psychiatry records will always comment about how the parent seems. Home health, we have the outcome assessment information set, OASIS, that needs to be addressed. And included within that is the treatment plan, the health assessment, the problem list, the treatment goals, and any interventions and outcomes. And again, a lot of times when you think about what's happening in healthcare today, both the federal and the state initiatives on documentation are evolving. They are trending to become more detail oriented to promote not only improvement in quality of patient care, but value-based care. A lot of times, a lot of interest now on social determinants of health, right? And the idea is we collect all this information, and hopefully, if somebody's health is impacted by social determinants of health, we can work with them and help them get services to improve their health care. And now we have different reimbursement models that provide incentives for quality of care, the MIPS, MACRA. And then from Joint Commission, we have the core measures. An example of core measures is for all heart failure patients, they need to have the ejection fraction documented with a numerical value, and discharge instructions need to have instructions for the patient to weigh themselves. Those are just two of the elements that are for the Joint Commission core measures for heart failure. With paper health records, we had a lot of different formats, the universal chart order, integrated health record, problem oriented, the SOAP notes, right? SOAP meaning that somebody comes in, they say, I don't feel good, right? That's subjective. Objective is why they don't feel good. Maybe their respiratory rate or their O2 saturation level is low, right? The assessment, the provider works them up, decides that they have an exacerbation of COPD, and then they have a plan. We're going to increase albuterol or what have you. That's a basic SOAP note. Electronic health records do all that, but they take it one step farther, right? Now we have scanning. So when a medication is given, frequently somebody will use a scanner that has a UPC code and put in the dosage, the type of med, and so on. And this way the documentation is captured electronically. Back when I first started in healthcare, one of the largest departments in the hospital was the X-ray file room, right? Now, of course, all X-rays are digital, right? So we have all these PACS systems and other web-based document imaging. And this is basically creating a digital image of whatever the diagnostic imaging is, be it an X-ray, MRI, CT scan, whatever. So now this is my last slide. What are the roles of the healthcare professionals, including the health information management professional in documentation? And it's important to think about this is that everybody has a role and they need to, as some would say, stay in their lane. Physicians document so quality care can be rendered and appropriate reimbursement can occur, right? So they need to document things at a finer level of detail, right? Not enough to just say pneumonia. Now we want them to come out and say whether it's viral pneumonia, bacterial pneumonia, or whatever it is. All right. So we can code it and reimburse them appropriately. Nursing documentation requirement will vary based on the licensing and regulatory requirements and internal policies and procedures, right? But they document certain things. Nurses have their own progress notes, their own assessments and things that are different from the physician providers. And allied health professionals, many follow treatment plans developed by the patient's physician, therapist, or technologist. So in other words, if you have a PTA, they may document something, but it'll be under the direction of the physical therapist. Now, for the moment you've been waiting for, HIM and documentation. Health information management professionals serve a vital role, and it may vary a little bit depending on what their role is in the HIM department. If they're in an administrative capacity, they'll be responsible for the administrative oversight to make sure these documentation requirements are being followed, right? Coders and billers will use the same information that's from the health record to do coding and reimbursement. Just a couple of other HIM roles that I should have mentioned earlier. A lot of interest, particularly with people that thought they wanted to be a nurse for the rest of their life, but may not. A growing area is clinical documentation integrity coordinator. In other words, how can we get providers to document and articulate things at enough of a level of detail so we can actually code it correctly? The other one is analyst. There are a growing number of analyst positions where people will look not only at the narrative documentation requirements, but ways that we can mine the electronic health record and run queries and other reports to help enhance patient care. And this kind of leads to the last bullet point, which is about informatics. Informatics professionals take this one step beyond. So we're not just getting health data, we're getting it and processing it into meaningful information. And I hope you found that useful. Please reach out if you have any questions about any of this material, and we'll see you online. Bye now.